Osteoporosis is the progressive loss of bone tissue and bone mass, as well as microarchitectural deterioration leading to weakening of the bone. There is an imbalance between bone resorption and bone formation. Now, this is a feature of normal aging and is inevitable in all elderly patients. However, in osteoporosis, the bone density that results from this imbalance is dramatically reduced. This illustration demonstrates the difference between normal bone on the left and osteoporotic bone on the right. A DEXA scan compares your bone density with the bone density expected for a young, healthy adult. The difference is calculated as a standard deviation score. A bone density more than 2.5 standard deviations below the young adult mean value, or a t-score less than minus 2.5, suggests osteoporosis. The pathogenesis of osteoporosis is as follows. There is always a small decrease in bone formation with every cycle of bone remodeling, and in senile osteoporosis, osteoblasts have their biosynthetic and proliferative ability reduced. Osteoporosis can also happen due to poor physical activity of an individual. Mechanical force on the bone stimulates bone remodeling, and this is why athletes will have an increased bone density. However, someone with decreased physical activity will have bone loss. In addition, decreased estrogen levels can leave someone prone to osteoporosis, and this occurs in menopause. A decrease of estrogen means that the rate of formation is less than resorption, resulting in a net bone loss. Also, increased osteoclast activity is significant in areas of bone with large surface area, such as the vertebral bodies, leading to vertebral compression fractures. There is a long list of risk factors for osteoporosis, however this is a short list of the important ones to be aware of. Family history, postmenopausal women, over the age of 65, people of Caucasian and Asian descent are more prone to osteoporosis, rheumatoid arthritis, poor physical activity, vitamin D deficiency and poor calcium intake, smoking, alcohol use, medicines such as warfarin, lithium, proton pump inhibitors and steroids, hyperparathyroidism, hypothyroidism, multiple myeloma, malabsorption syndromes, and decreased testosterone. Osteoporosis can leave a person prone to sustaining fractures due to the low bone mass associated with it. It is important to assess a person's risk factors for fractures, including a person's risk of falling. Risks of falling include confusion disorders, medications like sedatives, antihypertensives, neuromuscular diseases, alcohol use, environmental factors such as poor lighting or uneven floor at the home. As mentioned previously, the vertebrae can be particularly prone to fractures in people with osteoporosis. These fractures are often asymptomatic and may be discovered incidentally on X-rays. They can also be extremely painful and can result in kyphotic deformity, height loss, increased back pain, and decreased activity. This illustration is to demonstrate the kyphotic deformity, which is also called Dowager's hump. If we look at an X-ray of a compression fracture, you can see here the outline of the vertebra itself has changed shape from a normal vertebra. This is characteristic of an osteoporotic fracture of the vertebral body. The management of osteoporosis in general includes lifestyle measures. These include smoking cessation, reduction of alcohol, weight-bearing exercises, a calcium and vitamin D rich diet, also the use of supplements, and home-based fall prevention strategies. Pharmacologically, bisphosphonates are used first line to treat osteoporosis. These include alendronic acid. These are anti-resorptive agents and work by directly and indirectly inhibiting osteoclasts. As mentioned previously, calcium and vitamin D supplementation is a good idea, and hormone replacement therapy can prevent osteoporosis in postmenopausal women. Raloxifene is a selective estrogen receptor modulator that acts similarly to HRT, and teriparatide is the first line in patients with a very high risk of fracture. Treatment of vertebral fractures specifically can either be non-operative or operative. Non-operative would include observation, bracing, and medical management, and the majority of patients are treated in this way and are gradually returned to activity. Operative management is less commonly used for the treatment of vertebral fractures due to osteoporosis. However, there are 3 techniques that are listed: vertebroplasty, kyphoplasty, and also surgical decompression and stabilization. These surgeries should be carried out when patients still have ongoing pain and symptoms from a vertebral fracture, despite the fact that non-operative treatment has been carried out. Vertebroplasty and kyphoplasty are similar medical spinal procedures, where bone cement is injected into a fractured vertebra with the goal of relieving back pain. Thanks for watching, and I hope you found this useful.